this is my honors presentation, the effects of rock-steady boxing participation on quality of life in Parkinson's patients. Parkinson's disease is actually the second most common neurodegenerative disorder. Each year, nearly 90,000 new cases are diagnosed in the U.S. alone. Age is the biggest risk factor, which means that as people get older, their chances of developing Parkinson's increase. It's also more commonly seen in men than in women. And interestingly, prevalence can vary depending on where someone lives. Some geographical areas show higher rates than others, though the reasons for that fully aren't understood yet. Though environmental concerns like chemicals and other pollutants have certainly been cited as potential causes. This map expresses the areas of higher prevalence of Parkinson's disease. The higher incidence areas indicated in purple were Southern California, Southeast Texas, Central Pennsylvania, and Florida. We can see the green states up in the far northwest, western Midwest, and mountain west, and these are the areas of lower incidences. The pathophysiology of Parkinson's is quite complex. For the purposes of this presentation, we'll keep it very simple. Parkinson's disease affects both motor and non-motor pathways. The main culprit for Parkinson's disease is the accelerated death of dopaminergic neurons. Dopaminergic neurons are responsible for secreting dopamine. Dopamine is essential in orchestrating many processes in our body, including movement and emotions. It is hypothesized that by the time symptoms of Parkinson's begin to appear, 50 to 70% of dopaminergic neurons have already been affected. One of the many pathways they say cause this loss of neurons is inhibited lysosomal activity. Lysosomes are responsible for identifying and discarding abnormal proteins. Without this system, we have a buildup of abnormal proteins in our body to cause dysfunction. So this image shows us the difference between a healthy neuron on top and on the bottom is a neuron that has been affected by Parkinson's disease. We can see that the little green dopamines are much less prevalent on the bottom than on the top, and that leads to tremor, slow movement, and rigidity. Parkinson's is experienced by everyone differently, but here are some of the more common symptoms of Parkinson's disease. They include tremors, bradykinesia, which is slow movement, rigidity, postural instability, and on the non-motor side, we often see fatigue, apathy, which is lack of emotion, anxiety, and depression. Exercise has recently emerged as a good alternative to some pharmacological treatments for Parkinson's disease. Aerobic exercise offers health benefits, improved fitness, and reduces symptoms in people with Parkinson's. There are risks to exercising, as with everyone, but we can see that the benefits outweigh the negatives. On the benefits side, we see improved physical fitness, decreased scores in the Motor Disorder Society Unified Parkinson's Disease Rating Scale, which is used to just classify the severity and progression of Parkinson's, and improved health-related quality of life and decreased motor and non-motor symptoms. The risk of falls and cardiovascular complications is not really PD specific, and the same can be said for poor compliance. So the challenge is getting PD patients and everyone involved in a workout schedule that works for them. So for Parkinson's, in comes Rocksteady Boxing. Rocksteady Boxing is a non-profit organization that provides Parkinson's-specific non-contact boxing fitness classes. They do exercises to target both fine and gross motor impairments. This can include aerobic exercise, strength training, core stability, balance, and flexibility. They also work to foster socialization and empowerment within the group. Morberg and Associates did a study to investigate the effects of high-intensity physical training on symptoms experienced by patients with Parkinson's. They had 24 participants who they randomly assigned into two groups. The intervention group had 16 weeks of personalized physical training, which equates, they did 2 classes a week for 16 weeks to get 32 classes. A control group was used to compare the effects of physical training. This group was given simple, generalized recommendations for physical activity. Following the 16 weeks of physical training, it was found that the average unified Parkinson's disease rating score had significantly improved. The specific subscores that had increased were activities of daily living, motor, mentation, and complications. This study concluded that high-intensity exercise has a beneficial effect on motor and non-motor symptoms in people with Parkinson's. In this study, they took 12 subjects who had been diagnosed with stage 1, 2, or 3 Parkinson's disease and who had been participating in a community boxing program for about 6 months and retrospectively analyzed their data regarding the timed up and go test and the Fullerton Advanced Balance Scale. The timed up and go test assesses fall risk, balance, and mobility. It involves rising from a chair, walking 3 meters, turning around, and returning to the seated position. Between baseline and post-intervention testing, there was a statistically significant decrease in TUG scores. The Fullerton Advanced Balance Test consists of 10 tasks that the participant is asked to perform on a scale of 0, indicating failure, and 4, indicating perfection. There was a statistically significant increase in these scores. The findings of this study indicate that community boxing program participation was associated with improvements in balance and fall risk reduction in individuals with Parkinson's. In yet another study conducted by Larson and Associates, 1,709 participants who had Parkinson's and had at least heard of Rocksteady Boxing were given a 20-minute survey that covered things like demographics, PD characteristics, individual exercise habits, attendance to Rocksteady Boxing classes, and the effects that attendance had on motor and non-motor impairments. It also included the Parkinson's Disease Questionnaire 39, the Self-Efficacy for Exercise Scale, and the Starkstein Apathy Scale, which are all validated outcome measures. Scores of the outcome measures were compared between the current Rocksteady Boxing participants, the previous Rocksteady Boxing participants, and the people who had never participated. It was found that current Rocksteady Boxing participants had better PDQ-39 scores and better SEE scores. This indicates better health-related quality of life and higher exercise self-efficacy in the people who had participated in Rocksteady. The last study took 8 participants from a Parkinson's class, which is the Danish equivalent of Rocksteady Boxing, and interviewed them. They also had been able to participate/observe 4 classes. The interviews lasted 30 to 60 minutes and included questions about symptoms, motivation, quality of life, and other forms of training. The interviews were transcribed and analyzed for themes. Patients reported improved social health and sense of community, improved flexibility, gait, and coordination, in addition to improved ability to manage everyday tasks. Using the studies that I cited on the last 4 slides and other literature, I came up with my research question. My final research question was, how does participation in Rocksteady Boxing influence the quality of life in patients with Parkinson's disease? To complete this study, I first had to obtain permission from the Wayne State College Institutional Review Board. To answer my question, I implemented a mixed method study with a qualitative and quantitative portion. For both portions of my study, I recruited participants from the Providence Wellness Center Rocksteady Boxing class. The Rocksteady Boxing classes at PwC are each 60 minutes long and are offered 3 times a week. There are 4 coaches that rotate leading the class, and the program usually consists of 5 to 10 boxers. The 8 participants were all men and were between the ages of 56 and 81 years old. All of the participants had been participating for at least 14 and a half months, but on average they'd actually been participating for 56 months. There were 8 subjects in the quantitative portion of my study. Participants were asked to sign a consent form giving me permission to gain access to their data through Providence Wellness Center. Data from PwC included age, gender, occupation, date of first class, attendance records to Rocksteady Boxing, and their testing data. The tests were conducted every 6 months. The testing data included the 30-second sit-to-stand test, the 5-time sit-to-stand test, a functional gait assessment, the mini-best test, grip and pinch strength, gait speed, and the ABC self-confidence scale. I was looking for change across the testing sessions. Due to scheduling conflicts, I was only able to interview 7 of the 8 participants involved in the quantitative portion of my study. These participants consented to a 20 or 30-minute interview. Following the interviews, I transcribed the audio recordings and analyzed them for common themes across all the interviewees. These are the 8 main questions I asked during the interview. So the first one was, when did you receive your diagnosis and how has Parkinson's affected your everyday life? Why did you initially start participating in Rocksteady Boxing and why do you continue to participate? Have you experienced any changes in your Parkinson's symptoms since you began participating in Rocksteady Boxing? How has Rocksteady Boxing influenced your social life, energy level, physical confidence, and mood? Can you tell me about your occupation and or your hobbies? How has rock steady boxing affected your ability to complete tasks associated with your occupation and or hobbies? Do you think that rock steady boxing has had an impact on your overall quality of life? If so, how? What would you consider the biggest benefit of rock steady boxing participation and why? And are there any areas of your life that you feel have not been impacted by rock steady boxing participation? And if so, what are they? To analyze the quantitative data, I calculated the difference between the testing sessions from the first and last testing sessions for all tests. This is the absolute data. However, there is no statistically sound way to compare the data across individuals, as many have been tested on different days. To manage this, I took the difference between the first and last testing sessions and divided that by the number of rock steady boxing sessions that individual had attended during that time. This made the data relative to attendance and therefore could be compared across all of the individuals. To do all of these calculations, I used Microsoft Excel 360. I then calculated the absolute and relative mean, standard deviation, minimum, and maximum for each test. To analyze the qualitative data, I transcribed the audio recordings taken during the interview and used them to identify themes across all of the participants' answers. This table displays the results from the quantitative part of the study. So we see the absolute average change, standard deviation, minimum, and maximum. The absolute data reflects the change from the first testing session to the last testing session, and the relative data reflects the change from the first testing session to the last testing session divided by the number of attended rock steady boxing sessions. We're going to look at each of these tests in more detail, but before I show them to you, I want to give you a small disclaimer. Because of the diverse way Parkinson's is experienced, it is difficult to put a number on the change that is actually seen. We need to be mindful that while the group may show decline for particular tests, there were some individuals who did see improvement. Additionally, Parkinson's symptoms are variable and not always the same day to day. If an individual had an abnormal day on a testing day, then the data could be skewed. The 30-second sit-to-stand test is simply completing as many sit-to-stands as you can in 30 seconds. This box and whisker plot shows us how the data is dispersed. The whiskers, or the two lines that go up and down, show us the maximum and minimum, while the box gives us an idea of where the overall middle ground is for the group, with the X indicating the average. So for this particular test, we can see that on average, the individuals in this study were able to do more sit-to-stands at their most recent testing session than at the first testing session included in this study. I recognize that the numbers are very small for this graph, and all of the graphs, because they depict the relative data, so they're all going to be pretty small. The 5-time sit-to-stand test involves doing 5 sit-to-stands as fast as you can. This graph shows that there was very little change on average. The blue line represents the median or the middle point for the data. For this test, it's pretty close to 0. For this test, we actually went to see the numbers go down as it is a time test, so numbers in the negative are the numbers that indicate a positive change. The functional gait assessment consists of 10 walking tasks that simulate everyday life. The tasks include walking at normal speed, walking at different paces, walking with horizontal head turns, walking with vertical head turns, pivot turns, stepping over an obstacle, gait with a narrow base of support, walking backwards, walking with your eyes closed, and using the stairs. And this graph shows us the data for that. The mini-BEST test involves 14 balance-based tasks in order to assess balance ability and identify fall risks. For this graph, we see both the right and left hand grip strengths. These measurements are taken using a hand dynamometer. And the finger pinch strength test is taken using a finger dynamometer. For this test, again, we're wanting to see the time go down. For this, we just time them walking at a certain distance. And on this graph, we see almost all the participants are below 0. The ABC self-confidence scale is filled out by the individuals, and it just asks questions about how comfortable or safe they feel doing activities like going up the stairs, getting in the car, or walking on the ice. While some participants did decrease in scores, which is to be expected with a degenerative disease, We also saw participants increase their scores or at least experience no change. The group data, while interesting, is not necessarily a good indicator of the change truly experienced by the individual participants. Parkinson's is experienced very differently by everyone who has it, and in the group that I used for my sample, there's a variety of disease stages. This data was obtained through the interviews. I interviewed 7 people, and of these 7 people, 6 experienced positive social changes, 6 experienced positive energy level changes, 7 experienced positive physical confidence changes, 6 experienced positive mood changes, and all 7 reported that rock steady boxing had an overall positive impact on their quality of life. Of these 7, when I gave them the option of small, medium, or large, 4 reported large change, 1 reported medium to large change, and 2 reported medium change. Participants reported positive changes in their social life, energy level, physical confidence, and mood. In the study done by Larson and Associates, they found very similar results. In their study, 70% reported improvements in their social life, 63% reported improved fatigue, 62% reported less fear of falling, and about 60% reported improvements in depression and anxiety. And all of the subjects in my study reported an improvement in quality of life, and the Yusuf et al. Study reported similar changes in their study. All the participants I interviewed also emphasized the importance of camaraderie that they found through rock steady boxing. In another study, they reported similar results. A participant from my study reports, at first I heard some people say, we're brothers, and it's like, I don't know if I buy into it, but I do now. 4 participants even reported that a classmate is the inspiration for them, and that was seen in other studies as well. One participant stated, people like blank, he keeps coming, he's a fighter. Participants reported that feeling good, camaraderie, and staying active in their family are reasons that they continue to partake in rock steady. Another participant went as far to say that it makes me feel like Superman. This study is not without limitations. I was only able to use a small number of participants. In addition, it was a retrospective study, which means I had no control over any outside variables that could have occurred and skewed my data. I also was not able to use a control group. Additionally, I did not take into account extraneous conditions like medical treatments or activity outside of rock steady boxing. In conclusion, participants saw improvement in their quality of life, especially in their social lives, energy levels, physical confidence, and mood. This data supports the literature that rock steady boxing could be beneficial in relieving some symptoms that are experienced by people with Parkinson's. I would like to take this time to say thank you to everyone who contributed to this project. So thank you to Providence Wellness Center, Andrea Bilecki, Heidi Keller, Aaron Lemon, Michael and Kimmy, and a big thank you to the rock steady boxing participants who were able to help me with this study. And thank you to Dr. Fox for helping me through all the paperwork associated with this project. And here are my references. And finally, thank you all for coming and listening.